Hi, I'm Logan Lambertson, and today I will be doing an ankle assessment on Andreas using the form of HOPS. And in the acronym, the first letter H stands for history, and so these are the history questions that you would ask your patient. Something I'd start off with, if I didn't have immediate patient history, is just like their name, or well, I'd know their name, pretty sure, at least. I know Andreas, and I'd ask age, because age has a lot of risk factors. In various things, but today in an ankle assessment, that age could be anything from weak tendons due to older age or weak brittle bones. So I'd start off in one of the 6 categories of history would be what they do in their pastime. These are things I'd ask, like do they exercise daily? That can have a huge effect on ankle strength. What they do for a living. If they play any sports along with any daily activity, what their job requires, depending on their occupation. If it's a physical job, their ankle could be weaker or stronger, or a sedentary job, also vice versa. And then how often or how long they exercise daily. If they only exercise for 5 minutes a day, it's not going to be the same as someone that exercises for 2 hours a day. The second point in history questions would be the primary complaint of the person. So that would be anything from, was it hot or cold in the injury? Does the pain increase or decrease based on certain activities? Is the pain constant, or is it happen periodically or only occasionally does the pain occur? Is there any swelling specifically the ankle for this ankle assessment? Would also be another question you'd ask for their complaint. The third topic I would choose is the mechanism of injury, so how the injury occurred. These things would be anything from, is this an injury that slowly occurred over time, or is it something that happened immediately? When you had the injury, did the pain come instantly? Or like earlier, the first question, did it occur over time? What kind of exercises do they do? That'd be sort of along with the pastime, but like what kind of exercises? Because if they are someone that goes to the gym and only does upper body all day, that could be effective in terms of their ankle strength. Have they ever been in a car accident? Or maybe this came from a car accident would be another question for mechanism of injury. And then based on this ankle assessment, did this come from a direct trauma or direct blow to the ankle? Or was it that they stepped in a hole and rolled their ankle? So for the fourth characteristic or kinds of questions that I'd ask for history is what are their symptoms like, or the characteristics of their symptoms? Does it, on a scale of 1 to 10, how much does it hurt? Or is it itchy or burn? So the sensations that they feel on their ankle. When they wake up in the morning, does it feel fine and then it gets progressively worse throughout the day? Or is it always the same pain all the time? Because that could be, if it's a tendon thing, the tendon will heal overnight or start to heal overnight, and then it would re-injure throughout the day, and so you'd be back to square one. Another question would be, is there pain during exercise, or does it go away when you start exercising and then come back after you're done exercising? Would also be another question to evaluate the injury. The fifth sort of questions that I would ask is what limitations does the ankle injury have? So like, does it prevent you from walking properly, or can you not point your toes to the sky or press down on the gas pedal? Another question would be, can they go upstairs? If you can't go upstairs, that'd be another key factor. How much discomfort are you in when you put pressure, or is the pain the same regardless of how much pressure is on? And then how much weight can they bear on it? If it's too painful to bear any weight, that shows the pain levels, or if they're perfectly fine putting weight on it, it may be something else. And then the last set of questions I'd ask is their past history. So what their past is like in terms of this injury. That's things like, have you had an injury to this before? If they rolled their ankle multiple times, they may be more susceptible to this injury. Do you have like a family, like hereditary condition that your family has? such as diseases like diabetes can affect things. If this happened during sports, did they continue to play right after they got the injury, try to just run it off, or did, as soon as it happened, they come off and allow it to rest? And those are the sort of questions I'd ask for history. So here I will be performing the O part of the acronym in HOPS, which is observation. From here we're looking at the standing view, standing anterior view of the ankle. And so we're looking for out of the line toes, or maybe they have pigeon-toed feet, or any sort of other deformity in how they stand or the way their toes are. That can be anything that you write down in your assessment. Now for the medial view of the ankle, we are looking for high or low arches, or an excessively large medial malleolus. Then when we go to the lateral view of the ankle, we are looking for any swelling on the lateral malleolus, or any prominences or bumps on the posterior calcaneus. Then for the posterior view of the ankle, we are looking for a neutral position of the foot, or a slight valgus pronation of the foot, which Andreas does have here, so he's looking good. Then when he stands on his toes, you can see that the heel or the calcaneus slightly turns in, or is varus in position. So he's looking good there as well. Then for his gait, or the way he walks, you want to make sure that he's walking properly and taking even strides. So you have them walk forward. He's looking good there, and then have him walk back. And everything is looking good there. You want to make sure that he's not limping. That's an obvious sign of an ankle injury, so he'd have a limp, or also known as an uneven weight distribution on the foot. And yeah, that's observation. For the P in the HOPS, we are doing palpation, and so that's feeling around for any abnormalities or things that have gone wrong in the ankle or around the ankle. We start with palpating the medial and lateral malleolus for any tenderness or swelling or discoloration of either of them, and they're all looking good there. Then we move to the Achilles tendon in the back, where we feel for any rupture or tenderness or any swelling as well. Just like any other tendon, those are the things you would search for. Then we move to the peroneal tendons, which are responsible for eversion. So when you have your patient evert their foot on their own, you can see the flexion of these tendons as they run along the lateral side of the fibula, down and behind the lateral malleolus and into the foot. And those are also there, so he's looking good. Then we move to the anterior part of the ankle, where you feel for the talofibular ligament as well as the calcaneofibular ligament, and searching for any tenderness or swelling there, or possible breaks if they broke that tendon, and those are there, so he's looking healthy. Then we move down to the plantar fascia, where we look for any swelling or tenderness that would also be evident of plantar fasciitis, which is just, you have that almost all the time, which could be the injury that they come to you for in this assessment. So now we move and palpate the sesamoid bone and the tendons around there, because they could be injured from things like turf toe. And so that'd be something that could key into the ankle assessment, is if they have a turf toe injury or any sort of problems with their sesamoid bone. Maybe it's broken. That could also lead to potential problems. Then you would palpate the metatarsal phalangeal joints, make sure that there's no tenderness or inflammation there as well. And he's looking good and isn't in any pain right now, so he's healthy. For the S part of HOPS, we are doing special tests, and the first set of special tests that I'll be doing are muscular special tests. So With the patient, the first muscle we'll be testing is the anterior tibialis, where the foot is in plantar flexion. So you have your patient plantar flex, or tell them to push down on the gas or flex their calf. Then you prevent them from inverting and dorsiflexing their foot, so turning their foot in and pulling up. So you have them do that, and he's looking good there. Next, you do a similar thing for the posterior tibialis, where their foot is plantar flexed, and you just simply resist inversion. That's all you have to resist. And so he's doing well there. Then we move to the peroneus longus and brevis. And so you resist their eversion. So the tendons out here, you resist eversion, so you can be pushing inwards and have them try to evert their foot. Is looking good. And so those set of muscles, you'll see the flexion in the tendons there. Then we move to the extensor hallucis longus. So while their ankle is neutral, you will resist their extension of the big toe. So push down right around the big toenail and have them try to extend their big toe. So you're able to do that with no pain and relative ease. Then you will do the same thing at a neutral angle, ankle position again, and resist their flexing the big toe. So you put it just at the base and have them flex their big toe. And that is to test for the flexors, flexor hallucis longus and such, as opposed to the extensors. And then lastly, something you would test for muscular wise is the gastrocnemius, or also known as just the calf muscle. So while their ankle is dorsiflexed, you'll be pushing against the foot and resisting their plantar flexion, or tell them to push down on the gas while you will resist that. And those are the muscular special tests. Then for normal special tests that you'll be performing on them solely just for configuration of the ankle and making sure everything is attached properly. Those are the special tests that you personally perform on them. So you'll start with something like the anterior drawer test, where while the ankle is slightly plantar flexed towards 20 degrees, you will stabilize the tibia, which is I am doing is with my right hand, and then you will grab the foot from behind and pull upwards while you're keeping the tibia and fibula in place. So you'd be pulling upwards on the ankle from the calcaneus and testing the ligaments that hold that in place. Then you would proceed to the varus stress test, where you will again stabilize the tibia, and then with your foot on the calcaneus again, you would then invert the foot, testing for stress on the lateral ligaments and tendons that hold the ankle. And then you do a similar thing for the valgus stress test, where you hold the tibia and fibula down in a sturdy position again, grab the calcaneus and evert the foot. And that would be a lot harder due to the deltoid on the medial aspect of the malleolus. Those set of tendons there are much stronger than the ones on the lateral, which is why eversion as an ankle injury is more common. Then you would move to the MTP, or metatarsal phalangeal instability test, where you'll apply valgus and varus stress on the big toe or any of the toes. So you'd be pushing inward at the base and outward at the top, and then outward at the top and inward at the base, making sure everything is stable and that there's no problems going on with any of the toes or at the joint. Lastly, you would test for the Morton's neuroma test, where you would compress the metatarsal phalangeal joints together. So you'd be squeezing the toes together, and then you feel along or palpate the metatarsals for any bumps or abnormalities that may indicate a break or stress in the tendons that run along the top of them. And that is HOPS for an ankle assessment. Thanks.